In this video, we will discuss locked-in syndrome, different structures involved in this syndrome, and the clinical features. So what's locked-in syndrome? Locked-in syndrome is a bilateral infarction of the pons and lower midbrain due to hemorrhage or complete occlusion of the basilar artery or in the distribution of the posterior cerebral artery. Basilar artery has three groups of arteries that supply pons, cerebellum, and cerebellar peduncle. The paramedian branches of the basilar artery supply medial 1/3 of the pons, and circumferential branches supply lateral 1/3 of the pons. And the long circumferential arteries, superior cerebellar and anterior inferior cerebellar arteries, they also supply pons and cerebellum. How basilar artery is formed? It is formed by the union of the two vertebral arteries, and on the other end it's connected to the circle of Willis and to the posterior communicating arteries. So the most common cause of the strokes are infarction in 85% cases and hemorrhage in 15% of the cases. The syndrome may also be caused by trauma, tumor, or demyelination. What's the most common cause and site of basilar artery obstruction? Atherosclerotic obstruction of the proximal basilar artery. Syndrome may also be due to occlusion of the vertebral arteries. TIA in basilar artery or its branch occlusion are short-lived and they last for 5 to 30 minutes. TIAs occur several times a day. Why? Because of the intermittent obstruction to the blood flow. Multiple TIAs warn an impending infarct that is going to block the blood vessel. What's the difference in TIA of basilar artery or its branch occlusion? TIA of basilar artery occlusion is bilateral and TIA of basilar artery branch occlusion is unilateral. What structures are affected by the basilar artery occlusion? The long tracts are affected: corticospinal, pyramidal tract, corticobulbar tract, cerebellar tract, lower cranial nerves, and the ascending sensory tract. Clinical features of the locked-in syndrome. Patient is unable to move, speak, or show facial expressions, but he can see and hear and reply with vertical movement of the eye and blinking movements of the eyelids. Patient has quadriplegia. Why? Because of bilateral corticospinal tract involvement causing upper motor neuron type of paralysis with spasticity, hypertonia, hyperreflexia, and bilateral positive Babinski sign. Second feature is aphonia due to corticobulbar tract involvement innervating the lower cranial nerve nuclei. Patient has horizontal gaze palsy, complete and bilateral horizontal gaze palsy, and internuclear ophthalmoplegia due to bilateral involvement of the abducens nucleus. So bilateral involvement of the abducens nucleus causes paralysis of the ipsilateral lateral rectus muscle and contralateral medial rectus muscle because it is connected to the contralateral oculomotor nerve nucleus via the medial longitudinal fasciculus. So both the lateral recti and medial recti are paralyzed, causing complete and bilateral horizontal gaze palsy. Vertical eye movements are normal. Why? Because the supranuclear oculomotor pathways lies dorsally and are therefore spared, so vertical eye movements are intact. So in locked-in syndrome, horizontal movements are absent and vertical eye movements are present, and the blinking reflex is also present because levator palpebrae superioris muscle is intact. There is no facial expression and no pain perception. Patient is alert, awake, and conscious. Why? Because the reticular formation is not involved. So what functions are normal in locked-in syndrome? Patient is alert, awake, and conscious. Eyes are open. Blink reflex is present because of the levator palpebrae muscle. Vertical eye movements are also present. Pupil reactions are normal. How about the sleep cycle? Normal sleep-wake cycle, and EEG shows normal sleep-wake cycle.